Good afternoon, and as it was said, I'm doing this presentation on behalf of Shannon Lynch, who unfortunately could not make it for this workshop. Well, as you know, Médecins Sans Frontières, or Doctors Without Borders, we are a medical humanitarian organization. So as an organization, we work on access to healthcare, and we advocate for it. So in our operations, we don't have RCTs integrated. We do implementation research or operational research, trying to demonstrate then the feasibility and the acceptability of tools, strategies, and policies for which we have evidence from science. With regard to scaling up treatment, and then in particular treatment as prevention, in fact we are proposing here, for our advocacy messages, to use more and more the term of well, working towards becoming and staying undetectable. So aiming at HIV-infected people to become and stay undetectable for the sake of their own health and for preventing transmission. Now, what I'm presenting to you here in this presentation, it's in fact an overview of our implementation research with regard to treatment as prevention. So we cannot go into detail in the respective studies which we are planning to do or which we have started to do, but we can share with you, we will share with you some preliminary findings, and you will see also that quite some of the initiatives, the pilot initiatives which we are planning, have not yet started. But definitely compared with last year, we can already share with you some preliminary findings. So, well, as an organization, well, besides our other operational priorities, we are involved in supporting HIV care and treatment for about 220,000 people in 23 countries. Before we worked also in Latin America, but now we're focusing ourselves more and more on Sub-Saharan Africa, and we are also working in a few countries in Southeast Asia. The priorities for MSF with regard to supporting scaling up HIV treatment, it's important again to underline that first and for all, as medical humanitarian organization, we are concerned about the treatment gaps. So addressing those treatment gaps in low coverage countries and for people not accessing care in the high coverage countries. Secondly, we feel that as a priority that we should promote community approaches and self-management to enhance long-term treatment retention and effectiveness. And third, well, we are prepared to pilot accelerated ARV treatment, or let's call it specific treatment as prevention projects. That in a strategic matter to try to demonstrate feasibility and acceptability, and if indeed it works, and if we can demonstrate how if we can contribute to show how it can be done, then to contribute also later on to the scaling up once it is adopted by health authorities. Well, with regard to that accelerated ARV treatment, our role, as I said already, well, it's about demonstrating feasibility and acceptability of PMTB plus treatment, well, according to CD4 below 500, but we heard this morning, of course, that WHO is moving now with recommendations to those eligibility criteria, but also test and treat beyond pregnant women and lactating mothers, beyond serodiscordant couples. But all that without displacing, or let's call it crowding out, the people who are the most in need of ARV treatment, so who are symptomatic, have CD4 below 350, and or, well, WHO stage 3 and 4. So let's not forget that. Well, without displacing them, we could also say prioritizing them, as it was said this morning in the presentation by WHO. When we work on accelerated ARV treatment, we feel that we should not go for it directly. We have to be concerned about the cascade, and I think many partners in this room here, I think we all agree about it, that we have to work on the cascade, reinforce and extend that from HIV testing all the way up to treatment retention for the sake of effective treatment response. We feel also that we have to have the mechanism in place for proper ARV treatment follow-up, and then especially out of, and in particular, as we said already, strategies of organizing that follow-up out of health facilities, at community level, and self-management. Third, viral load monitoring, and we are coming back on that, is for us a key strategy in support of that accelerated ARV treatment. And then linked to that, well, targeted adherence support through enhanced adherence counseling for people who are detectable. Well, to start with the ARV follow-up and self-management, well, you probably have heard about, well, the experiences they are with community patient groups. And ourselves, we have contributed to that by documenting what we are, by documenting the experiences with working with community patient groups, for example, in the context of TET in Mozambique, the community ART groups. We are now also doing that in Tiolo in Malawi and in other contexts. But there are also other organizations working on that. We also look at the strategy of treatment clubs, health facility linked, which is probably a strategy for ARV follow-up and self-management better adapted to urban contexts, like we are documenting in Kailicha in South Africa. But third, it doesn't have to be always community linked. We are also looking at, well, patient self-management stricto sensu, people on their own managing themselves with a highly simplified medical follow-up. For example, we are looking at the possibility, at the feasibility of once-a-year medical appointments, like we are going to try to pilot that in Chirazu and in Malawi. Viral load monitoring. Well, as I said in the beginning of this presentation, the viral load, we should use that more and more as a motivation tool. Get and stay undetectable. We see that already, and I will come back on that with our experience in Sicilween in Swaziland, that indeed the message from getting your CD4 above 200 and above 350 is moving towards, well, becoming undetectable. And so that's a very strong tool which we can use in motivating the people to adhere to their treatment. Secondly, it is important, let's not forget, for the early detection of adherence problems, triggering then that targeted adherence support. And third, of course, the early detection of treatment failure with a timely switch to an appropriate second-line treatment, and eventually later on, if needed, third-line treatment. And last but not least, well, viral load monitoring is becoming a key in the program monitoring. It's part of the metrics framework as it has been developed by WHO and other partners. It allows to look at community viral loads as a proxy for incidence, and of course it allows then to assess formally the treatment response, and then like that will evaluate programs with regard to the targets being set. The access to viral load monitoring, we have been implementing, and we are implementing several implementation studies with regard to how to improve the access to viral load monitoring. And we don't only speak about point of care. Well, in fact, point of care, of course, the point of care technology is arriving in the months and years to come. But we are also looking at laboratory-based viral load monitoring, because if we are going for scaling up, including treatment as prevention, even the more radical test and treat, we need to have high throughput, as the laboratory technicians are saying, for viral load. So in that case, we anticipate that we will have to continue to depend on laboratory-based viral load technology. But we are looking at how to reduce that complexity by, for example, and that's what we have recently documented, well, the validation of finger prick-based DPS for viral load testing through for example, the NucliSense by Milieu viral load platform, and we did that in Tiolo in Malawi. We are also looking at how to reduce cost, and so we have recently implemented a study about pooled sample testing for people who are undetectable, who are stable and undetectable already since some time. And we have demonstrated that indeed there is opportunity to reduce the cost of that type of viral load testing. And so all that helps, of course, towards the final purpose of routine viral load monitoring. We are involved in field validating new and current tests, point of care and laboratory based. In fact, we are implementing a multicentric diagnostic project study, which is financed by United, on access to laboratory and point of care viral load, as well as also point of care CD4 tests. But specifically, I think we have started now to pilot the point of care Samba viral load in Malawi, which has been developed supported by MSF, and in fact it's one of the first point of care technology which becomes available in in such a low resource setting. Last, viral load testing. Well, of course, we see as a goal to go for routine viral load monitoring, but we can introduce it in a phased approach, starting with triggered viral load monitoring and later on eventually expanding it to routine viral load monitoring. Targeted adherence support through enhanced adherence counseling. Well, there's an area of implementation research. We want to look at, well, what are the core components within that additional or stepped up adherence counseling, which makes a difference in addition to the routine follow-up and the viral load testing. We are looking at how to diversify approaches and then to quantify the added effect of these approaches. And last but not least, well, the workforce. Who is going to do that? Are we still speaking about lay people, or will we have to involve also health professionals, as this is a higher level, a maybe more complex level of adherence counseling? Well, MSF project piloting accelerated ART. Last year I presented a similar slide with studies, and I must say that I'm sorry, but this is the reality, that we cannot fill in more, let's say, the column of where we have started. But definitely we have started in Langano Health Zone in Sicilian region in Swaziland, and Dr. Okello referred to it with regard to piloting PMCB+. And already since some time, and that's part of the national program, of course, in Malawi, we are doing that. We are doing operational research with regard to PMCB+ in Chiradzulu and Tiolo in Malawi. PMCB+, we are planning to start it also in a project in KwaZulu-Natal. We might start to pilot it also in Mozambique, in Kenya, and also in Gutu district in Zimbabwe. Now, putting people on treatment according to CD4 below 500, of course, this is going to become a global recommendation from WHO, but we have planned to do that in KwaZulu-Natal, and we might also do that in Kenya and in Zimbabwe. Now, test and treat beyond pregnant women and lactating mothers and serodiscordant couples. We are proposing to do that also in the Langano zone in Swaziland, and complementary to what Dr. Okello just presented through the MaxArt program. We are looking at how to also pilot on test and treat for serodiscordant couples in Malawi, as well as in KwaZulu-Natal in South Africa. Well, the KwaZulu-Natal project, very briefly, it's a project which has a title, Bending the Curves, and it aims at reducing the incidence of HIV and TB. It will take place in, well, it has started since now 2 years in 2 areas, rural and semi-urban. It has a population of more than 100,000 people. Well, the epidemiology of HIV you're well aware of, so KwaZulu-Natal is one of the areas in sub-Saharan Africa among the most affected by HIV, but also TB and even MDR-TB. So the general objective of that program is to reduce HIV and TB incidence, and specifically then to demonstrate successful strategies for testing, treatment, and prevention of HIV and TB. What we have started in that program is, well, the entry into care and linkage. We have not yet started with the earlier ARV treatment, because and that's the reality, it takes time to come to an agreement with the health authorities and the research platforms involved. But what we can say is about HIV testing in 2012, well, that took off quite well, and I think the HIV testing has increased more than 3 times what took place through the health facilities. So through mobile one-stop services, through community health workers and out-of-clinic fixed sites. But those community HIV testing and counseling at community level, in fact, of course it has a high uptake, but it detects less people who are HIV positive compared with HIV testing at health facility level. And that's what you can specifically in the mobile one-stop service, where you see the prevalence levels in community sites, farms, schools, and primary schools. So we have to think carefully about, well, with our limited resources, where are we putting our energy? Do we aim for getting a maximum of people and getting to know their status, or are we looking for identifying first the people who are HIV positive? So that's a balance, and we have to think carefully about it when we speak about strategy for testing and counseling. Well, and so HIV testing at facilities, I said, well, they tested only 35%, but in fact 63% of the new HIV positive diagnosis. The linkage from mobile testing is still limited in that setting. It's around 40%, and it's especially difficult for the young people. The testing coverage overall, it's improving, so we are now about at 40% of the total population. Briefly about Shishilweni region, Swaziland. Well, it's a program where we are working on cascade reinforcement and step-by-step test and treat in one health zone. First started with PMTCB Plus and then proposed to be followed by test and treat for adults. Dr. Okello presented on the epidemiology in Swaziland. Well, we must say in Shishilweni region, for example, the ARV coverage is already very high, has reached probably universal access, and with quite good retention levels, but HIV testing is lagging behind. So we added community-based testing, but again the challenge is, well, the positive thing is that we reach more men, and that are the bars in the red. But what is still the setback is that the linkage doesn't work that well. These are still preliminary findings, and it's a small number of people, but during 1 month we looked at linkage, and we found that about 20% actually linked to health services. The routine viral load monitoring in Shishilweni, well, that's already, we have now done viral load testing for close to 9,000 people, and in fact what is impressive is that the overall majority are undetectable. And then what we also want to say is that among the people who are detectable, we looked at about 226 patients with follow-up viral load results who got their enhanced adherence counseling, and well, close to 50% had achieved viral resuppression. We have similar data from other settings, and where it's even higher, the resuppression after enhanced adherence counseling. Definitely an important strategy to be included, to be linked to the viral load testing. Piloting PMTCB Plus, it took off, but of course we are showing here preliminary data. Well, the first findings for less than 3 months, we have a high uptake, and the majority, well, here in this, among these 63 will have a CD4 above 350. Then the last project I want to say something about is the Yolo Malawi, which is involved in the rollout and the evaluation of the PMTCB Option B Plus program in Malawi. So they have set up a prospective study using linked electronic databases. They do it in partnership with the Ministry of Health. And well, during a 12-month period, they looked at about 911 women and 279 infants were enrolled. And that study will continue. It's looking at different aspects of the PMTCB Plus program. But the most important thing to say here is that the loss to follow-up in the first 6 months on ART was 21.5%. And so that's worrying. For the rest, the uptake for nevirapine prophylaxis was okay. But as we know in many PMTCB programs, well, the uptake for the PCR test, early infant diagnosis, was still insufficient. So that for the uptake has been excellent, but high rates of loss to follow-up. Infant PCR testing at 6 weeks is still, of course, below the levels as required. But so, thanks for your attention.